Hello, and thank you for your attention. My name is Professor Bill Walter from Sydney, Australia. The title of my talk is Sagittal Stability and Knee Designs. I'd first like to thank the organisers for allowing me to speak, and I'm very privileged to be part of this esteemed panel with Dr. Baxten and Blaha and others. And I'm sorry I couldn't be there in person. My disclosures are listed here. I do receive royalties from a manufacturer that makes a medial pivot knee. So instability is one of the major causes of revision in total knee arthroplasty, along with infection and loosening. Instability may be early or late. I'd like to refer to some work by George Bergman, where he put transducers in knees and measured the forces. And you can see most of the forces are perpendicular to the joint surface. But where there are forces in the other direction, they tend to be in an anterior-posterior direction, seen in this man kneeling. So in this case, the blue force is the anterior-posterior force, which is 250 newtons. This creates a shear across the bearing, depending on the design. Other movements like this alternating step forward from this patient have even greater anterior forces. It was 400 newtons of anterior force in this example, which creates a shear force across the joint. So we know that we can break the forces and moments acting on a knee replacement into different planes, the transverse, coronal and sagittal plane. And I think the sagittal plane's most important because of the antero-posterior forces on the knee. We see varus valgus instability sometimes in knee replacement. That is coronal plane instability. We can see hyperextension instability, but it's the anterior-posterior forces that produce an instability with patients that have painful swollen knees that I think often goes unrecognised. When we do a total knee replacement, we sacrifice a lot of the stabilising structures. We remove the menisci, the anterior cruciate ligament, and sometimes the posterior cruciate ligament. Then we replace it with a knee replacement that may be one of different designs. The diagnosis of instability, we can see patients with a valgus or varus thrust. We can assess the coronal plane, valgus and varus. But for anterior-posterior stability, the manifestations are a little bit different. We see patients that are uncomfortable going up and down stairs, as an example. They may have recurrent effusions and they're dissatisfied. And we can assess the unstable knee with an anterior draw test after a knee replacement. So a number of years ago, we looked at the sagittal stability of 4 different knee designs. There were 3 cruciate retaining and 1 medial pivot design, and we matched patients for age, gender, and BMI. We used a KT1000 to put an anterior force and measured anterior tibial displacement at 30 and 90 degrees. We found a lot of the knees were unstable, as you can see here in these 2 photographs, with the tibia translating forward about 10 millimetres. When we divided the patients by stability, there was no difference in the age, BMI or gender. But when we divided by stability, there was a significant difference in a lot of the patient-reported outcome measures, particularly the forgotten joint score and Coues Sport, but also these other scores. So you can see Coues Sport here had the greatest difference. And the questions that we ask in Coues Sport are: do you have difficulty squatting, running, jumping, twisting, pivoting, and kneeling? So these are all the activities where you have significant antero-posterior forces on the knee. And I believe this creates a shear. And if the knee is unstable, it'll create symptoms for the patients. Remember our patient who had the 400 Newton anterior force with that alternating step action. So this is how I explain it. We've got 3 different knee designs. There's medial stabilised, cruciate retaining, and cam and post knees. And when you've got this force that's not directed straight down, but it's directed a little bit forward, you have that force can be resolved into a shear force and a normal force in the round on flat design. So the cruciate retaining and the cam and post tend to be round on flat. the medial stabilized knee will be a normal force at the functional positions of the joint, and so there's no shear force. So you don't require ligaments to stabilize the knee. So the shear force, if there is a shear force to be resisted and you balance the knee perfectly, you'll have a stable knee. But if you don't balance the knee perfectly and you have some laxity in your ligaments, then the medial stabilized knee will still be stable, but the cruciate retaining and the cam and post, or the round and flat designs, will be somewhat unstable. So I think that's why we have these differences in stability with medially stabilized versus non-medially stabilized. So in that same study, we found less anterior translation at 30 degrees and 90 degrees of flexion in the medial stabilized versus the non-medial stabilized. And that correlated strongly with the joint scores, Coues joint replacement, Womack and Oxford, etc. We can also simulate the kinematics of a joint, and this is work done by 360 a number of years ago. They looked at subject and implant-specific deep knee bend simulation by getting preoperative imaging, landmarking, and then doing the surgical planning and simulating the movements. And we can actually simulate those three different knee designs, cruciate retaining, posterior stabilized, and medial stabilized. And we can see what happens to the center of rotation. And you can see the center of rotation moves paradoxically forwards in the cruciate retaining and the posterior stabilized before rolling backwards. This is just the center of rotation of the medial facet. Whereas in the medial stabilized knee, it's very stable in the first 90 degrees of flexion, indicated there in red. And then it rolls back in deeper flexion in blue. So there's been talk recently about conformity ratios, which is the ratio between the femoral component and the acetabular component. And I'd just like to make an analogy in hips. So in hip replacements, if we're doing a 36 millimeter cup, we'll put a 36 millimeter head in to have a conformity ratio of 1. A conformity ratio of 0.76, which is present in many designs, would be equivalent of putting a 27 millimeter head in a 36 millimeter cup. You can imagine in a hip, if you put a 27 head in a 36 cup, it wouldn't feel stable. Well, the same things happens in a knee. If you don't have a conformity ratio of 1, the knee feels unstable. And of course, the conformity ratios get down much lower. So these are examples from 6 different designs. The medial stabilized knee has a conformity ratio of 1, all the way from full extension to 90 degrees of flexion. Only at 120 degrees of flexion does the radius change on the femur, and you lose your conformity and your stability. The graduated radius design progressively loses conformity as you go down, so it becomes more and more unstable. And in the 15 to 30 to 60 degree range, which is a lot of the functional activities, it's actually quite unstable. Cruciate retaining knees, where they're round on flat, posterior stabilized knees all have conformity ratios of less than 1, leading to some level of instability. So in conclusion, extension instability is not tolerated well and may lead to revision, but flexion instability is related to inferior patient-reported outcomes, especially sporting activities, and more congruent knees are inherently stable. Thank you for your attention.